Hello guys, good evening. Welcome to today's class. So today we are going to discuss some important topics in general surgery, mainly pediatric surgery and some investigations, radiological investigations. So that will cover a lot more of general surgical concepts. I am following Bailey and Love pattern. So that is how I have structured my classes. You must have seen the earlier three classes. We had metabolic response to trauma, then we had uh, sepsis, shock, those kind of topics. Yesterday we did laparoscopic surgery, robotic surgery. So today we will go one step ahead. We'll do pediatric surgery and some amount of investigations, basically radiological investigations. If you guys can see me and hear me clearly, I can read your messages in the chat. So please give a thumbs up if I am audible and visible. If you can see the slide, if you can see me well. I can see you guys on my phone in the YouTube chat box. Okay, great. So as people are joining in, let me give you a brief introduction about how the class is going to be constructed and a little bit about myself. So I am Dr. Amrit Nasta. I am your surgery educator on the Unacademy platform. That's me right there. If you wish to learn more from me, if you want to get updates about my upcoming classes, follow me on the Unacademy Learning app. You can download it and then you will get updates about my upcoming classes. There are a lot of nice, wonderful educators on the platform, and if you wish to learn from them, if you are targeting NEET PG 2021, there is a last mile course which has just started on 1st Feb. So definitely you should subscribe to the Plus platform and remember to use my referral code, that is 10 surgery. That will get you a 10% discount on whatever subscription model you choose. Whether it is Plus model, the iconic model, 1 month, 2 months, 3 months, whatever duration you take, use my referral code. A lot of educators like me are teaching on the platform, and that will cover your preparation comprehensively. An important announcement I want to make: Unacademy Combat. We have already had 2 editions of Unacademy Combat. The third edition is this Sunday, same time, 5 p.m. The subjects this time are OBGY, PSM, and microbiology, if I'm not mistaken. So this time it is third year and final year subjects. The earlier two were on first year and second year subjects. So whatever happens, do go for this. A lot of amazing prizes to be won, and of course you will get a ranking. It will be a national ranking, so you will know where you stand in your preparation. Otherwise we sit comfortably at home, we don't know where we stand, but this will give you a national ranking. And it's only 45 questions, 1 hour, okay, on Sunday at 5 o'clock. Do go for it. There is nothing to lose and too much to win. There are a lot of amazing prizes to be won. There are vouchers and free subscription plans and so on. So go for it, guys. Okay, so I will start the class. Please reply in the YouTube chat box. Okay, so please reply in the YouTube chat box on the questions. The first half is going to be pediatric surgery. I have already taken a special class on clinical questions in pediatric surgery. This will not be overlapping. So if you want to cover pediatric surgery more, you can go and view my special class. It's a free class. It's called Clinical and Image-Based Questions in Pediatrics. I just took it a few days back. Good evening, Ritesh. Alright, so you can go through that. Today we will be covering other questions in pediatrics and radiological investigations important in surgery. Okay, so let's begin the class. Let's begin with something basic in pediatrics. I am asking you to identify the incorrect statement. Okay, identify the incorrect statement about pediatric surgical principles in contrast to adults. Now, obviously, surgery in a child is going to be different from surgery in an adult because anatomically they are very different bodies. You know, a child has a much bigger head than an adult. Infants, neonates, their proportion of the head is much more. Similarly, there are other proportions which vary. So that has a bearing on pediatric principles compared to adults. Which of these is incorrect? All of these lines are taken from Bailey, mind you. I have just changed one option a little bit. Okay, so you will find this in Bailey. Most of the questions today are from Bailey. My intention is कि आपका at least one standard surgical book should get covered comfortably, right? So, does a child have a wider abdomen with reduced vertical distance? Bladder is mainly intraperitoneal. Ribs are more horizontal and rigid, and umbilicus is lower down than in an adult. Acha. Datesh and Pratik are both going for umbilicus is lower than in an adult. You are saying this is wrong. मैंने incorrect पूछा है. So whatever you are saying, please keep in mind you are committing that the other statements are correct. Okay, and this is a very basic level question. This is the first page of the chapter on pediatric surgery. Just say I have taken these points. Okay, Pratik has given two answers. Pratik, only one answer is correct, na? Or rather, only one answer is incorrect. Don't give two answers. Okay. So we will dissect the question appropriately, so we know what is right, what is wrong. Let's look at the first point. Wider abdomen and reduced vertical distance. This is correct. The abdominal wall or the abdominal space compared to an adult in a child is relatively broader. So the ribs are like this in a child. Here will be the umbilicus. This will be the pelvis. Okay, so it's relatively, the length, superior inferior length is relatively less, the width is more, so this statement is correct. What is the bearing of this statement? Why is this important? That the vertical distance is less, the abdomen is wider in a child. What is the bearing of this statement? So the important point about this is most pediatric surgeons, when they do a laparotomy, they take a horizontal incision. Yeah, absolutely right. Most of the times they take a horizontal incision. In adults, we always take vertical incision. Most of the times, right? But if you see a child, if he's undergone a surgery, the incision will be horizontal. That's because in an adult, the superior inferior length is more. So laparotomy vertical gives a good exposure. In a child, you need a horizontal incision. Bladder is mainly intraperitoneal. This is correct. This is because the pelvis is shallow. It is not well developed. The depth of the pelvis is not yet there. So bladder is shallow. Pelvis is shallow. So bladder is mainly intraperitoneal. This is correct. Ribs are more horizontal. This I already told you. But are they rigid? Are they rigid? Unfortunately, ribs are not rigid. In children, all bones overall, especially the long bones, are fairly flexible. So I just changed the word rigid instead of flexible. Actually, it is flexible. What is the bearing of this? What is the bearing that the ribs are flexible? They are not rigid. They are fairly flexible. But yes, they are horizontal. So half was correct, but this is the statement that I changed. Umbilicus is lower than in an adult. This is also correct. The superior inferior length is less, so the umbilicus is lower. As the abdomen grows, the umbilicus comes more towards midline. What is the bearing of this line? That the ribs are flexible. In general, bones are flexible. In general, in pediatric population. How does that have a bearing? Yeah, anybody? Pratik, DBB, Datish, incision for laparotomy. Yeah. In fact, most of the bones are flexible. The bearing of this is a rib fracture in a child is very rare because the ribs are flexible. Long bone fractures in children are rare because they are flexible. You know, if the child falls on an outstretched hand, what fracture does he get? If an infant falls on an outstretched hand, what fracture does he get? Little bit of orthopedics. What fracture does he get? Supracondylar. That is in a little older child. That is in a little older child. That is 3 to 10 years of age. I am saying maybe 1 year, 2 years. If he falls on an outstretched hand, what fracture will he get? Clavicle. No, clavicle is birth trauma. That is birth trauma. It's called a green stick fracture. Green stick. उसमें क्या होता है, only one cortex breaks, other cortex is intact, other cortex only bends. Green stick fracture. Okay, that is because the bones are fairly flexible. Similarly over here, if there is a rib fracture in a child, it is unusual. If there is long bone fracture in a child, it is unusual. You will suspect foul play. It's a sign of abuse. Okay, so if a child is brought to the emergency, 1 year old, 2 year old, 3 year old child with rib fractures, that means he is being abused. Normally, the ribs don't fracture in a child. Wider abdomen, I already told you, horizontal incisions are preferable for exposure. Intraperitoneal bladder, because the pelvis is shallow, implies bladder trauma is easy. So bladder gets traumatized. Understand, even liver gets easily traumatized because in a child, the liver extends below the costal margin. In a child, about 2 to 3 centimeters of the lower border of the liver goes below the costal margin. It can be palpable. In an adult, the liver is never palpable unless it's pathologically enlarged. In a child up to 3 years of age, the liver may be palpable normally, so it is easier to get traumatized. Lower umbilicus. This I was telling you earlier. Bearing of lower umbilicus. If the umbilicus is lower, there is very little gap in the lower half. I cannot position a stoma in the lower abdomen. Okay, so even if I am creating an ileostomy, it is usually in the upper abdomen. Remember, stomas have to be away from umbilicus. They have to be away from umbilicus. They have to be away from scars. They have to be away from skin crease. So if the umbilicus is lower down, that room is not there to create a stoma. This is the bearing. Each of these point is absolutely crucial. ये एक एक point पे आपको MCQ आएगा. Okay, every point from this is MCQ worthy, is what I'm trying to tell you. Okay, now let's come to an image. Let's see if you guys have seen this. Similar image was there in NEET PG. Similar image was there in NEET PG 2020. What is the pathology? Yeah. What is the pathology in this image? What is the child having? Omphalocele. Is it omphalocele? Or is it gastroschisis? Tatesh says omphalocele. Or is it ectopia? You know what is ectopia? Or is it intestinal atresia? Similar image was there. This is a very basic concept that we must know. So obviously what you see here, this is a bowel which is protruding. Okay, but it is covered by the peritoneal membrane. You don't see bare bowel. If you are seeing the peritoneum covering the bowel, protruding through the abdomen, obviously this is the abdominal wall, this is the pubis area, probably here is the child's penis, probably. Since there is a covering, this is going to be omphalocele. Cele means cavity or covered cavity, right? Like you have enterocele, cystocele, that means a covered cavity or a cavity which has a peritoneal lining. That is the derivation of the word cele. So there is going to be a peritoneal lining or a peritoneal covering. Gastroschisis looks like this. This is gastroschisis. You see the difference. The bowel is bare. Okay, there is no peritoneal lining. This is gastroschisis. If I ask you which has a better prognosis between omphalocele and gastroschisis, what will your answer be? Which has a better prognosis? Omphalocele or gastroschisis? What will be the answer? Which is better? Omphalocele. Why is that? Why omphalocele has a better prognosis? ऐसा क्यों? Just because the peritoneum is covering it, it becomes better prognosis? ऐसा नहीं है. Understand, gastroschisis is an isolated abnormality. Okay, it is not associated with other problems. Omphalocele, on the other hand, has a lot of associated GI abnormalities, other system abnormalities. Okay, so the child may be having simultaneously midgut malrotation, some atresias, and so many other problems. So this carries a poorer prognosis. Omphalocele overall has other abnormalities. Gastroschisis is isolated, so you just have to treat the gastroschisis most of the times. Okay, you may put it in one stage or you may have to cover it with a bag. What is that bag called? What is the cover bag called? Sometimes you just cover it with a bag such that the edema reduces over a period of time and gradually you reposite the bowel and close the defect. What is that appliance called with which you cover Bogota bag? Okay, it's called Bogota or silo. Bogota bag or a plastic silo. What is this? What is this child having? What is this child having? Yeah, this is new. ये कभी this is my own image. Means this you will not find in any. This is not an online image. This is of an actual patient that I have seen. Bladder extrophy. Very good. This is ectopia vesicae. Now understand, ectopia vesicae literally means there is an exposed bladder over here in the lower abdomen and the anterior abdominal wall is deficient. But you cannot actually see the bladder. Okay, you will have the bladder trigon, but you cannot make out it is bladder. So don't expect anything bombastic. It looks nothing except a granulating wound. It looks like a granulomatous or a granulating wound. Okay, that's all you will see. What are these things underneath? What are these things? What do you see here? These two red things over there. Little weird looking. What are those things? Yeah. What are those red things that you see? Which are commonly associated with extrophy of bladder. क्या है ये चीजें? Any idea? Oh, okay. So these are probably bilateral inguinal hernias. Bilateral inguinal hernias. They are commonly associated with extrophy. Bilateral inguinal hernias. If it's a male child, then he will have undescended testes. What urethral abnormality is associated with ectopia vesicae? What urethral abnormality is seen in ectopia vesicae? What happens to the urethra? ये भी MCQ है. Yeah, what happens to the urethra? Epispadiasis, absolutely right. Epispadiasis. Okay, E for ectopia, E for epi. Not hypospadiasis. Understand, overall urethra, the most common abnormality is hypospadiasis. Overall. This is overall. But in ectopia vesicae, it is epispadiasis. Epispadiasis as such is very rare. So if you see a child who has epispadiasis, most of the times he will be having ectopia vesicae. So epispadiasis and ectopia vesicae most of the times go together. Isolated epispadiasis is extremely rare. Okay, it is extremely rare. Alright, this is a new question. Let's see who can figure this out. New high level question. Yeah. Identify the mismatch for the pathology and the ideal age of repair. Ideal age of repair. Congenital hydrocele 2 years, inguinal hernia immediate, umbilical hernia 4 to 5 years, supraumbilical hernia immediate. ये कभी आज तक पूछा नहीं है. आज तक ये पूछा नहीं है. Inguinal hernia immediate, he's saying is wrong. Anybody for any other answer? This is again directly from Bailey. Billion love. From that chapter on pediatric surgery. Array, it's an amazing chapter. There are so many things in that chapter. It's only like a 15-16 sites ka chapter with many images. But there are so many amazing things you can just pick and choose. Like this is my second special class, so to say, on just that chapter. Yes, Nurel, what's your answer? Nurel, Shivani, Suresh. Yeah. You have to find the mismatch. Huh? Pratish says congenital inguinal hernia immediate. Unfortunately, congenital inguinal hernias are operated immediately. This is correct. This statement is correct. Dr. Jyoti Sharma says congenital umbilical hernia 4 to 5 years. If not, then when should it be operated? If not 4 to 5 years, then when should we operate it? If you're saying this is wrong, what is the ideal age? Guys, this is not the kind of question you should get wrong. Huh? Let me be honest. It's not the kind of question you can make a mistake in. Immediately. Congenital umbilical hernia immediate. No, this is correct. Congenital hydrocele 2 years. This is also correct. This is the incorrect answer. Supraumbilical hernia is also operated at 4 to 5 years of age. Okay, so I will give you a list of ages and the timing of repair which you must know. Okay, which you must know. You can't do if you don't know any of this. Ages and repair of inguinal hernia. Obviously, I'm talking about congenital inguinal hernia, which happens due to patent processus vaginalis. Ideal age of repair, the word given in Bailey is prompt, promptly, or whenever diagnosed, or immediately. Immediate does not mean if the child comes today and is diagnosed, then you have to operate him tomorrow. It's not immediate. Immediate is not correct. It means you can't tell the mother that come at 6 months, 1 year, 2 years, or when you want. You can't tell her that because you will tell that it's a hernia. It's not going to go away. It will require surgery. Sooner the better. Lower the risk of complications. Okay, so you can't say if the child is born and the neonatologist sees the hernia, he will say get operated at 6 months, 1 year. ऐसा नहीं है. जब diagnose होगा within some amount of time, which is labeled as promptly, is when you should operate. When should you operate undescended testes? Anybody? ये तो आएगा. ये तो बहुत सर्जन ने पढ़ाया होगा आपको. सर्जरी, पैथोलॉजी सब जगह पढ़ा होगा आपने. या when do you operate undescended testes? This is not immediately. This is after some time. No, it's not immediate. Nurel, don't give such answers, yaar. You can't tell. It's not immediate. Undescended testes is 6 months to 1 year. Okay. अगर दोनों ऑप्शन दिए हैं, go for 1 year. The reason is undescended testes are usually associated with prematurity. If the child is born before term, because the testes descend at 9 months. So in most people who have an undescended testes at birth, if it's undescended at birth, usually by 3 to 4 months it descends down. Okay, usually by 3 to 4 months it descends down. The risk of malignancy can be reduced only if it is done up to 1 year. And mind you, the repair or bringing it down, orchidopexy, does not reduce the risk of malignancy. It only improves diagnosis. It only improves diagnosis. Risk of malignancy is not affected. Okay, malignancy is not affected. We have discussed this in my class on clinical questions in pediatrics. उसमें मैंने discuss किया undescended testes. Please go through that. I had put a question on incorrect statement about undescended testes. In that I have discussed. Risk of malignancy does not reduce. Pubertal growth is going to be better. So the testicular function will be there. But risk of malignancy does not reduce. Okay, only diagnosis becomes faster. Congenital hydrocele, already told you, 2 years of age. That's because this can resolve on its own. Okay, it can resolve on its own. Umbilical or supraumbilical hernias is 3 to 5 years. There is a waiting period. It's one of the few hernias in the body where you can wait. It is self-resolving. One of the few hernias which is self-resolving. Okay, congenital umbilical hernia. We are only talking about congenital, not adult. It is self-resolving. You wait for 3 to 5 years. Anybody knows what that is called? Waiting period for congenital umbilical and supraumbilical hernias. Wait for it to resolve on its own. What is that called? It's all given in the book. It's called masterly inactivity. It's called masterly inactivity. You can wait. Of course, unless it's a very big hernia, child is symptomatic, then there is no waiting. Age of repair of epigastric hernia. Congenital epigastric hernia. Anybody? I have not put it in the question because I thought it will be a little difficult. Congenital epigastric hernia. When do we operate? Anybody? New question. Only congenital, huh? Not adult. Oh, okay. This is when symptomatic. Okay, when symptomatic. This is the answer. Each of these points is from Bailey. I have taken a class on timelines in surgery. It's a free class. Please go through it. It's called timelines in surgery. बहुत ही अच्छी class है वो. Timelines in surgery. You can get it on my profile. तो कौन से एज में कौन से pediatric diseases present करते हैं which need to be treated, all of them are discussed. Almost all of them. Time to repair hypospadiasis and epispadiasis. Hypospadiasis is 18 months to 2 years. 18 months to 2 years. Epispadiasis का कुछ age नहीं है. Epispadiasis is a part of other problems. It has to be treated as a part of other problems like ectopia. Cleft lip palate, Datesh seen that class. I have given the breakup. Cleft lip कब करेंगे, cleft soft palate कब करेंगे, cleft hard palate कब करेंगे. हर एक का अलग अलग है. It's there in that class. You see this class. Timelines in surgery. I have discussed each component of cleft in that. Okay. Alright. This is a previous year question. This is not a new question. Apple peel type of intestinal atresia belongs to which type? So intestinal atresias are divided into multiple types. Okay. Apple peel type is which one? 1, 2, 3 or 4? This is a yes and no question. This is the kind of question if you don't know you should just let it be. नहीं आता तो छोड़ दो, आता है तो आना ही चाहिए. Be cool says C. Okay. Yes. Niaz also says C. Very good. That's correct. Apple peel type is type 3. Very good. We need to know a little bit. Anybody can tell me most common site of intestinal atresia? Most common site of intestinal atresia? Duodenum, jejunum, ileum, cecum. Yeah. Most common site of intestinal atresia? Nias says duodenal. Very good. That's right. Duodenal is the most common. Second most common is jejunal. It goes in this order: duodenum, jejunum, ileum. Cecum में तो कभी normally होता नहीं. So it's usually duodenum. If not duodenum, jejunum, then ileum. Apple peel type is type 3. I'll show you all the types. Don't worry. सारे type करेंगे. Okay. So I told you this most common site is duodenum. Duodenal atresia is associated with which diseases? Duodenal atresia is associated with which diseases? First tell me that. With which disease do you see duodenal atresia? And I need two answers. There are two diseases. Very good. One is Downs. What is the other? Down syndrome. What is the other? Very good. दूसरा कौन सा? Trisomy 21 नहीं नहीं. Not trisomy. Any other? Which other disease? It's a surgical disease. It's not a medical disease. They all present the same way, whether it's just duodenal atresia, whether it's duodenal atresia and Downs, or whether it is that disease where you get duodenal atresia. Are annular pancreas. Okay, normally the three of them come together. The treatment is the same, duodenostomy or duodenal bypass. सारा एक ही है. So whether they ask you treatment of duodenal atresia or they ask you treatment of annular pancreas, the treatment is the same, duodenostomy. ये जो types of intestinal atresia है, that is called jejunoileal. Type 1, 2, 3, 4. Type 1 means there is a membrane. Okay, the intestine is in continuity, but there is a membrane somewhere which causes intestinal obstruction. Type 2, there is actual missing or atretic segment. There is a cord-like segment, so there is actual missing segment like this. So a part of the intestine is actually atretic. That is type 2. Type 3 is this, apple peel. Okay, and type 4 is multiple sausage-like atresia. So you see, this is probably proximal bowel. This is one atretic segment. This is other segment. This is third segment. Beach mein there are missing segments. There is mesenteric loss. So you get loss of mesentery in type 4. Okay, so if they ask you mesenteric loss is seen in which type? Sausage type. Okay, but it can also be seen in type 3. So these are the two which are associated with mesenteric loss. Type 3, apple peel leg appearance. Type 4, sausage leg appearance. You can see 1, 2, 3 like that. It can be of any amount. Treatment obviously is going to be surgical. You have to do a surgical reconstruction or a surgical bypass. Okay. This question is also there in timelines in surgery, which I was recommending that you go through. Timelines. 5-year-old boy presents with acute scrotum. Pain worsens on elevating the testes. If you are performing a surgical exploration, when should it be ideally performed? Within what duration? 1 hour, 6 hours, 12 hours, or 24 hours? First, you need to identify what the disease is. 1 hour, 6 hours. Oh. What is the disease? And what is this test that I have done? Ragini and Shivani and Nias and Be Cool. Everybody is saying 1 hour. Nurel is saying 6 hours. What is this disease? Acute scrotum. Very good. This is testicular torsion. Excellent, guys. Excellent. So basically, and what is this test that I did? Pain worsens on elevating the testes. What was that? Prehensign. Absolutely right. That is called Prehensign. In Prehensign, I elevate the testes. If the pain increases, it is torsion, because when I elevate the testes, the ischemia will worsen. When I lift the testes, it will become more ischemic, so more pain. If the pain decreases, then it is epididymoorchitis. Right? Then it is epididymoorchitis. That is Prehensign. Angle sign and Deming sign are others. That they are different signs. So the question is only asking you, explore the testes, treat the torsion in how much time? Answer unfortunately is 6 hours. Most of you got this wrong. Answer is 6 hours. 1 घंटे में तो बच्चा पहुंचता भी नहीं है हॉस्पिटल तक. Let alone undergoing investigations, undergoing surgery under anesthesia and you untwisting it. इतना 1 घंटे में नहीं होगा. Right? Ideal time is within 6 hours. Obviously, the longer you wait, the more chance of gangrene. Okay, the longer you wait, the more chance of gangrene. That's what you need to know. I am not going to discuss testicular torsion. I just want to ask one thing: causes of acute scrotum in a child. Acute scrotum in a child. One was testicular torsion. What are the other differentials of acute painful scrotum? One was torsion testis. Other? Because the question will be exactly like this. It will be acute scrotum. And then they'll give you a scenario, which will be any of these. Yes, any other cause of acute scrotum in a child? Epididymoorchitis, of course. Any other? Acute epididymoorchitis. Any other? Trauma. If it's trauma, then it's trauma. Then it's not going to be a differential diagnosis. Trauma does not cause acute scrotum. Trauma can cause hematoma. हो गया ना? Epididymoorchitis दे दिया. Any other cause? Any other cause given in Bailey? Bailey has given 5-6 causes. Some are vague, some are important. I'll give you a scenario. Same patient. By the way, how do I confirm that he has testicular torsion? How do I confirm? Varicocele is not seen in children. Pratik, varicocele is seen in adults. How do I confirm torsion? Severe acute pain in the child. Testes is tender. How do I confirm? Like, if the parents ask, hey, doctor, are you sure it is torsion? Okay, don't say Doppler. Please don't say Doppler. Please say testicular arterial Doppler. Okay, please say this. Testicular arterial Doppler. It's not Doppler, it's arterial Doppler. So let's say the same patient, I did the testicular arterial Doppler and there was no ischemia or no evidence of torsion. No ischemia or evidence of torsion. What will you think? Because epididymoorchitis is also seen on ultrasound. Ultrasound will diagnose. USG will tell you, yes, the epididymis is swollen, there is free fluid in the epididymis, there may be a secondary hydrocele, all that will be seen. So, both are diagnosed on USG Doppler. And I am telling you, ultrasound is normal. What else will you think? And the child is having acute scrotum. Any other cause of acute scrotum? No, not trauma, Dr. Costa. Trauma, the child will tell you, na, he got trauma, now there is a hematoma. Hematoma you will see on ultrasound. And it's not going to cause acute scrotum, it will cause scrotal swelling. Let's say there is a scrotal swelling also, which is tender. What will you think? Other cause is strangulated hernia. Okay, strangulated hernia. But of course, strangulated hernia will also be diagnosed on ultrasound. Ultrasound will show there is intestinal contents into the inguinal and the scrotal region. Ultrasound will pick up. What if there is no hernia? The pain is still there, not relieved with analgesics. What will you think? Not seen on ultrasound. I mean, it's difficult to see on ultrasound. And it's a severe acute onset pain. Not going away. What will you think? What does Bailey say? Is there anything else that can undergo torsion? Is there anything else that can undergo torsion which will be hard to see on ultrasound? Anything else that can undergo torsion? Torsion of testicular appendage. Yes, cysts of Morgagni. Torsion of testicular appendage. They can cause or they can mimic torsion of testes. Okay, in a child they can undergo torsion, not in an adult. Torsion of testicular appendages. Remember this. If everything is normal, pain is not going, think of this. इस पे आज तक MCQ आया नहीं है. It's a fairly new topic. It's not that common, But if they want to go one step ahead, they'll give you this scenario and then they'll tell you, okay, ultrasound is normal, Doppler is normal. What is the next step? Of course, next step will be explore, but you will not see twisted testes, you will see torsion of testicular appendage, which can be excised, no problem. Okay, this is one of the easy questions of the day. So this I think everybody should get. This is not a very difficult question. Mother brings her 1-year-old son with colicky abdominal pain and a paraumbilical lump, which disappears. Thrombosis of pampaniform plexus. Why should there be thrombosis of pampaniform plexus? There is no reason for that to happen. So mother brings her son with colicky abdominal pain, paraumbilical lump which periodically disappears with pain-free intervals. So the child has colicky pain, sometimes he gets the lump with the pain and periodically the lump goes away, pain goes away. What is the child having? Lymphadenitis, intussusception, appendicular lump or hyperplastic cecal tuberculosis. Very good guys. So far so good. Answer is ileocolic intussusception. Absolutely right. What else do you expect? First thing, what is the age at which the child gets ileocolic intussusception? Age of presentation. Should it be 1 year or should it be something else? When should a child normally get ileocolic intussusception? Yeah, intussusception. When does the child normally get? Age of presentation. After 1 year. Infancy. Absolutely wrong. Answer is 6 months to 1 year. The best answer is weaning period. This will be your answer. Weaning period. Anybody can tell me why? Why weaning period? If you know the fundamentals, you will never forget. In NEET 2021, in 2020, they had asked a question on one of the signs of intussusception. That they will not ask again. Now they will ask you something like this. When does it normally present? It's normally seen in the weaning period. Why? As a cue. That's because in the weaning period, absolutely right, when the child starts consuming other foods, not breast milk, other foods, he gets gastroenteritis. No, not bowel movement. He gets gastroenteritis. And this gastroenteritis probably causes lymphoid hyperplasia. Because of inflammation, there will be lymphoid hyperplasia. And that lymphoid hyperplasia serves as a lead point across which the intussusception will happen. Now, I only want to ask one question, clinical question. The child will present with a lump like this. Okay, paraumbilical, sausage-shaped lump. Uh, what happens in the right iliac fossa? What happens in the right iliac fossa? So the child presents with a sausage-shaped lump paraumbilically, but there is something that you see in the right iliac fossa. What is that? Yeah. When you palpate in the right iliac fossa, very good. What is that called? The right iliac fossa is empty. Probably the intussusception has pulled the cecum medially. Probably. What is that called? Empty right iliac fossa. Nowadays, they ask so much of clinical stuff and not maybe they I don't think they will ask you those target sign and pincer sign anymore. They will ask you this. What is that called? Empty right iliac fossa. Dancing sign. Wow, exactly what I wanted to hear. Dancing sign. Okay, it's not called dancing sign. It's called sign of dance. But please understand, sign of dance. The word dance does not mean any dancing. Dance is the name of the scientist who discovered it. Okay, please understand, dance is the name of the person. It's not dancing maneuver or anything. There is no dance happening. The person who invented it, his name was dance. So it is called sign of dance, which is why I didn't want you to call it dancing sign. It's not dancing, it's sign of dance. Okay, so that was some pediatrics. Now let's do some imagings, basics of imaging. Tell me the incorrect statement about use of contrast media. All of this is from Bailey. There is one chapter in Bailey, section 3, called imaging. Then the chapter after that is endoscopy. We'll do endoscopy tomorrow in our last class on general surgery. I have not touched breast, thyroid, vascular disorders, endocrine disorders, skin tumors, oral malignancy, which we believe is general surgery, but that is just advanced general surgery. Okay, that is all advanced. I have restricted to basic general surgery, which if you get it wrong, it's a disaster. Yeah. Incorrect statement about contrast media and imaging. All patients should be observed for at least 30 minutes with IV line and C2. Routine prophylactic steroids for allergic reactions. All contrast media have potential nephrotoxicity and diseased kidney. Metformin increases the risk of lactic acidosis. Only 2 people have attempted. Okay. Yeah. So let's take each option. All patients should be observed for at least 30 minutes with IV line and C2. This is true because all contrasts, a contrast is what? A contrast is a heavy metal. Okay, it's a heavy metal. That is the main funda. It's a heavy metal, so if he drinks it, or if it is given intravenously and an X-ray is done, or a CT is done, or an MRI is done, it will appear dense or it will appear opaque. That is what a contrast is. It gives you a contrast appearance. Usually it's a heavy metal. Heavy metals can cause allergy. You know, copper allergy जैसे होती है काफी लोगों को. Similarly, barium allergy. So allergy is the most important complication. Okay, nephrotoxicity होती है, but only in diseased kidneys. Normal kidneys में nephrotoxicity नहीं होती. Normally नहीं होती. Routine use of steroids is not advocated. Okay, there is no role of routine use of steroids. Only if he gets an allergic reaction, you will give steroids. So there are some important points that I want you to remember here. Allergy and nephrotoxicity, they are the important complications. Whatever contrast you use, whether you use barium, whether you use gastrographin, whether you use urographin is used in a intravenous urogram, iohexol, they are all heavy iodine, heavy barium, all those are contrasts. Okay, please remember this. If the person is a diabetic, you must do a creatinine before giving contrasts, because you want to know, is the kidney disease, because if the kidney is disease, there can be nephrotoxicity. And the third, this is the one. This is new, ये आज तक पूछा नहीं है. In when we do MRI, we use gadolinium contrast. Please understand, if the person is having CKD and I use gadolinium contrast, which is why I need to know creatinine beforehand, a disease can happen called nephrogenic systemic fibrosis. This has not yet been asked. It's a very unexplored topic. Nephrogenic systemic fibrosis due to gadolinium contrast toxicity. Okay. More than the question, what's more important is the next slide, which I want you to get a good grip of. When I do a CT chest, it will give radiation equivalent to how many plain chest X-rays? Basically, a chest X-ray is taken as the baseline when I do radiology. Okay, and other contrast or radiation imagings are compared to chest X-ray. So if chest X-ray is say 1 baseline, how many times will a chest CT be? I hope you are aware, a CT scan is nothing but an X-ray. It is just a very high dose radiation X-ray with a lot of cuts at different levels. Very good. Answer is 400. So a CT chest is 400 times more radiation exposure than a plain X-ray. So you better think when you go into practice if you ask for a CT chest. Nowadays in COVID times we are doing HRCT chest so rampantly. So many people are getting exposed. If they ask you CT abdomen, what will be your answer? CT abdomen. How many times a chest X-ray? What is the radiation exposure in a CT abdomen? ये दो ही पूछेंगे और तीसरा विल बी पेट स्कैन. ये तीन आने चाहिए. What is the radiation exposure? I cannot give you numbers. You need to know the answer. Compared to a chest X-ray, what is the radiation in a CT abdomen and what is the radiation in a PET scan? Yeah, CT abdo. No, answer is not in one of these. Unfortunately, its answer is not in one of these. CT abdo is little more than a CT chest, so it is 500. How much is PET scan? Yeah, anybody? How much is PET scan? I'll show you all the important ones. 2 times, 1000 times. Wow. No, 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 no. It's not like that. Chest X-ray is 1. CT chest and abdo 400, 500. PET scan is 250 times. Okay, PET scan is 250 times, and the clincher is X-ray abdomen 50 times. X-ray chest. Both are X-rays. But chest compared to abdo is 50 times. ऐसा क्यों? ऐसा क्यों? Abdomen is 50 times more than a chest X-ray. ऐसा क्यों? Yeah, why? Anybody? ये सब बेली के numbers हैं. None of this is my creation. It's all there in Bailey. X-ray abdomen is 50 times and X-ray chest. Why? Solid organs. Okay. Better answer. There is more absorption of the radiation. More absorption of the radiation. Okay. So it is more absorption of the radiation. Okay. Now asking you the true statement about ultrasound. So that was about X-rays. Now let's come to ultrasound. Medical practice uses frequencies of 0.5 to 2. Higher the frequency, more the penetration. Air and bone cause attenuation. Ligament injuries are poorly seen. True statement. Huh? Each of this line is taken from Bailey. Each of these lines. I have just एक मैंने एक दो चीज ट्विस्ट की है to make everything incorrect and only one statement is correct. Only one statement is correct, na? Don't look for the incorrect answer. You never get someone as helpful as me. If only your NEET PG also had someone speaking to you every time you went to the question. Look for the true statement. Don't mark the false statement. It is from this book, that book. Yeah. Some people have answered C. Okay. मैंने देखा है जो नूरल आंसर देती है सब लोग वही फॉलो करते हैं. समझ करो. Every time she won't be right. Yeah. Okay, let's dissect each statement. In medical practice, frequencies used are 0.5 to 2 megahertz. What is the correct answer? What frequencies are used in medical practice ultrasound? Akanksha says higher the frequency, more the penetration. Great, I am happy to hear that. What frequencies are used in medical? And Ragini says D. Ligament injuries are poorly seen. Wow. Excellent, excellent, excellent. I'm so happy. So I think like the previous 3 classes where there were so many eye-openers, today's class will give you more eye-openers which may make you feel worse. You'll wonder, Sala, ultrasound may also I'm making a mistake. 2 to 10. No, Akanksha, it's not 2 to 10. It is 5 to 20 or 3 to 20. Bailey says 3 to 20. 3 to 20. It has to be more than 2. Okay, it has to be more than 2. Up to 2 megahertz is audible frequency. It has to be more than 2. Okay, it is inaudible. It is ultrasonic. Right, it is beyond the frequency of audible sound. So it is more than 2. It is 3 to 20. Higher the frequency, more the penetration. Absolutely wrong. Sorry, Akanksha. More the frequency, less the penetration. Which means if I am scanning for something superficial, thyroid, breast lump, okay, superficial, I don't need much penetration. There I use high frequency. I don't need much penetration. If I'm doing abdominal ultrasound, yeah, what is the frequency for abdominal ultrasound? Abdominal ultrasound में क्या frequency use करते हैं? If you knew this, you would have known this is not the correct answer. In abdominal ultrasound, where I want more penetration, I use lower frequencies, 5 to 7.5. For superficial, high frequencies, 7.5, 10, 15 तक जा सकते हैं. Abdominal, where I wanted to go in the depth, low frequency. Ligament injuries are poorly seen. This is absolutely wrong. All superficial injuries are well seen. That does not mean it's better than MRI. ऐसा नहीं है. It's not better than MRI, but superficial injuries, soft tissue injuries are well seen. Bone injuries are not well seen. Fracture के लिए मैं ultrasound नहीं करूँगा. Okay, fracture के लिए नहीं करूँगा. But fluid collection in a joint, septic arthritis, synovitis, joint effusions, muscle trauma, muscle hematoma, ultrasound is excellent. It is excellent. Okay, even if you didn't know, this you should have known. Air and bone cause attenuation. Attenuation means they reduce, they cause a hindrance. It affects visualization. This is absolutely correct. Ultrasound waves don't go through the bone. Ultrasound waves don't go through the air. Air and bone, they cause something that is called as acoustic impedance. They cause acoustic impedance. Acoustic means sound. Impedance means impede, means block. So if there is air, which is why we never do ultrasound for bowel, because bowel has air. It will not go through the air, so you cannot see lesions in the bowel. But yes, solid organs, ultrasound is awesome. Which is why first investigation for liver, gallbladder, renal disease, because they are solid, they are superficial. Pancreas not well seen, because pancreas is right at the back, bowel is in front. Bowel of course not well seen. Bowel के लिए ultrasound नहीं करूँगा. But yes, solid organs very well seen. Superficial organs very well seen. Ligament, tendon, muscle, ये Bailey की line है. So for abdomen, I need lower frequencies because I need more penetration. Alright, just a little extra point. Doppler, arterial Doppler, we just discussed a little while back. Arterial Doppler is based on reflection from RBCs. So the sound waves are thrown, and based on the reflection of sound waves from RBCs in the blood vessels, I get the Doppler shift. Okay, I get the Doppler shift. That's what gives me the direction of flow. It is based on the reflection from RBCs. Okay, new question. Which of these is not an absolute contraindication for MRI? Which of these is not an absolute contraindication for MRI? Now that I am teaching orthopedics also, I could have changed the question a little bit. Next time I will change the options. Which of these is not an absolute contraindication for MRI? Aneurysm clips, cochlear implant, ocular metallic foreign body, claustrophobia. I hope some of you have undergone an MRI and I hope they have asked you a checklist. ये तो नहीं है, ये तो नहीं है, ये तो नहीं है, ये तो नहीं है. I hope so. अगर आपका हुआ है. Alright. So yes, all of you are correct. Claustrophobia is the answer. Is claustrophobia a contraindication at all? Is it a contraindication? Claustrophobia. Is it a contraindication or no? Or it should not be a contraindication at all? It is a relative, absolutely right. It's a relative contraindication. Because understand, this can be overcome. If the person is having claustrophobia, I can do the MRI under sedation. So I can give him some sedatives and then do the MRI. Claustrophobia is something that can be overcome. If the question was not absolute, if it was not a contraindication, and let's say one option was instead of ocular metallic foreign body, if one option was titanium screws, what will be the answer? Then will you go for claustrophobia or titanium screws? You know titanium screws वो orthopedic में use करते हैं. Screws, plates, nails. You have two materials of orthopedic implants. One is stainless steel, other is titanium. So remember, titanium screws, okay, are MRI compatible. They are MRI compatible. When we do bariatric surgery, we use staples we discussed yesterday. You know, all those linear stapler, linear cutter, all those. The stapler pins are also made of titanium. Okay, so all those pins that I use in bariatric surgery, the staplers that we discussed yesterday, they are also MRI compatible. So if I had a sleeve gastrectomy and staples inside, does not mean I cannot undergo an MRI. Okay, because they are compatible. So these are some absolute contraindications. Pacemakers, everybody knows pacemakers. Where else is pacemaker a contraindication? To what other procedure? To what other procedure is pacemaker a contraindication? Yeah, it's in medicine. It's a procedure done in medicine. Where if the person has a pacemaker, you cannot do that. Monopolar cautery, no, that's I'm not saying surgery. That we did yesterday. Very good, Datish. For which medical procedure is pacemaker a contraindication? Oh, I'll give you another clue. Psychiatry. Defibrillation. अरे pacemaker है तो defibrillation की क्या जरूरत है? Pacemaker will only maintain the rhythm. Psychiatry, psychiatry. Shock, shock. Yeah, ECT, ECT. Absolutely right. Electroconvulsive therapy. Absolutely right. Okay, so MRI is the best imaging. See, so many MCQs in one slide. Best imaging technique: brain lesions, spinal cord lesions, musculoskeletal lesions, musculoskeletal or soft tissue. MRI is not so good for thorax, for GI. I am not saying abdomen. I am saying GI, for thorax and for heart. Means thorax means lungs and heart. It's not so good. That's because these are all in motion. Motion is an enemy of MRI. Like air and bones were an enemy of ultrasound, motion is an enemy of MRI. So wherever there is motion, MRI is not the best thing to do. Okay, MRI is not the best thing to do. आजकल करते हैं cardiac MRI. The technology has improvised, but between MRI and CT, if it's something in motion, CT is better. MRI not so good. Okay, just telling you the basic funda. Okay, new question. This is not there in Bailey, so finally I'm asking you something out of Bailey. What is this procedure? This is the biliary tree. Okay, You can see left hepatic duct, common hepatic duct, ऐसे कुछ कुछ लिखा हुआ है, common bile duct. And then something has changed. Okay, something has changed, and now they are looking different. What have I done? Is it a HIDA scan, percutaneous transhepatic cholangiogram, indocyanine green scan, or intra-op cholangioscopy? Wow, सब लोग HIDA बोल रहे हैं. Be cool. Ragini Datesh says HIDA. Akanksha and Nural say indocyanine green. Okay, okay. Anybody for any other answer? Nobody for PTC? Percutaneous transhepatic cholangiogram? ऐसे कैसे हो गया? Nobody for PTC. Nobody for intra-op cholangiogram. Doesn't this look intraoperative? You know, you are seeing things in surgery and then the color has changed. It's not intraoperative. Okay. Answer is indocyanine green. It's a new technology. It's come in the last 5 to 8 years. It's there in books, but it's not in Bailey yet. This is some of the things they can ask you. Okay, if you have never seen ICG, it's okay. You should have eliminated the other options. A PTC or a cholangiogram, any kind of a cholangiogram, okay, whether it's percutaneous, ERCP or intraop, is nothing but an X-ray. Better answer is fluoroscopy. So does this look like an X-ray? X-ray में green color कहाँ से आ गई? These two are straight away eliminated. HIDA scan is a scintigraphy. How do you see scintigraphy? Many of you called it HIDA scan. How does scintigraphy look? Any scintigraphy you must have seen thyroid scan. HIDA नहीं देखा तो thyroid scan तो देखा होगा. How does it look? It's a black and white. Black and white image, multiple stages. You will see say एकदम black liver. Then in the next photo you will see black liver with little biliary tree. Then black liver with biliary tree, gallbladder. काले काले picture होते हैं. It's a functional scan. Okay, it's black on white. It's a functional scan. How can it be HIDA? This is definitely an intraop imaging. This is indocyanine green. What is indocyanine green? I'll tell you very briefly. Okay, very briefly. Indocyanine green fluorescence is the correct name. Fluorescence. Now let's say I am doing a cholecystectomy and I can't make out whether the duct that I am seeing, is it a cystic duct, is it a hepatic duct? I can't make out. So what I do, I give this contrast ICG intravenously during the surgery. Okay, now this ICG is excreted in the liver, in the bile. Okay, it is excreted in the bile. So when I give it intravenously, the contrast goes in the liver. It's not really a contrast, it's a fluorescent dye. Then it is excreted in the biliary tree, in the bile duct. Okay, so all I have to do is after I give the injection of ICG, I wait for a few minutes and then I just change the light of the camera. We did yesterday. Optics, light source. So the light source normally gives white light. I just change the light. It is a setting. I change the color of the light. When I change the color of the light, wherever there is any fluorescence, that becomes highlighted. The fluorescence gets highlighted. So I'm able to see the anatomy. So it will delineate the anatomy of the fluorescent compound. Because then I will be easily able to see the fluorescence in the bile duct. Maybe in the gallbladder also if I want to see. So I will know it's a bile duct, it's not an artery, not a lymph node, anything that's coming in the way. वो सब हट जाएगा. That is ICG. Okay, आज तक इस पे सवाल आया नहीं है. It is very useful for biliary anatomy, vascular anatomy. Okay, because you don't need any X-ray exposure. You just change the light so that the fluorescence gets emitted and then you can make out the anatomy. Very easy technique. Okay, last question of the day. Never asked. Expected question. It's there in Bailey. Daycare surgery or a day surgery. They can also call it day surgery. Involves admission and discharge within. 12 hours, 23 hours, 24 hours, or overnight? Okay, I got overnight, I got 24 hours. Any other answer? What is a day surgery or a day care surgery? Again, 24 hours, 24 hours. आज की क्लास में तुम लोग को गूगली बहुत लगी है, ऐसा मुझे लग रहा है। नॉर्मली इतने रॉन्ग आंसर्स नहीं आते, नॉर्मली नहीं आते। एटलीस्ट Datesh, Nurel, they normally give correct answers. They have been with me, I think, in the last whole month. But today, most of you are all over the place. Yeah, anybody? Day surgery or daycare surgery means you should be admitted and discharged within how much duration? Aha, I gave a little push to Nurel and then she changed the answer. Yes, absolutely right. Please remember, answer is 12 hours. Okay, there are 2 points that we need to remember to call something as a day surgery. He should be admitted and discharged within 12 hours on same date. There should be no overnight stay, even if it's less than 12 hours. Okay, what does it mean? Day surgery means you come in the morning, say at 8 o'clock, your surgery happens at 10 o'clock, and you are discharged by 5 or 6 in the evening within 12 hours. That does not mean you come in the night at 10 o'clock because you had an appendicitis, get operated at midnight and get discharged the next morning. वो भी 12 घंटे के अंदर कर सकते हैं. But then it's not called day surgery. Day surgery means it should be within 12 hours on the same date. If he stays overnight, it is called overnight stay. Okay, it is called overnight stay. Each of these is important. But I'll tell you the most important one. Day surgery or same day surgery, admitted and discharged within the 12-hour day. Same day, same date. Date has to be same. Overnight stay means 23 hours admission with early morning discharge. Right? So if he comes at 7 in the evening and gets discharged next morning at 7 o'clock, it will be called as overnight stay. It will not be called as day surgery. Overnight admission नहीं होना चाहिए. And if he stays for more than 23 hours but less than 72 hours, it is called short stay surgery. Okay, it is called short stay surgery. These are the definitions you need to know because घुमा फिरा के वो आपको ऐसे ही पूछेंगे. घुमा घुमा के. They will give you a clinical scenario. Patient came with right iliac fossa pain to the hospital at 6 in the evening. Ultrasound was done at 7 in the evening, diagnosed with appendicitis. Since patient was starving, surgery was done at 9 in the night. Next morning, patient was discharged at 6 in the morning because he had to go for CET exam, NEET exam. He said, doctor discharge me, I have to go for NEET PG. What will you label this as? You will say, sir, 12 घंटे के अंदर discharge हो गया. Day surgery. It's not day surgery. It should be on the same date. If he stays overnight, it's called overnight surgery. And overnight should also be within 23 hours. If it's more than 23 hours, up to 3 days, it is called short stay surgery. Okay, are we very clear on this? No doubt at all, I hope. I hope today your eyes have opened a little more about general surgery. Tomorrow your eyes will open even more. Tomorrow we meet again, same time, 6:30 p.m. General surgery part 5. Also tomorrow 8 p.m. Tomorrow 8 p.m. special class. Okay, that special class will be on the platform. You need the app for that. So there is a special class, integrated revision of cancers. I'll discuss a few cancers comprehensively from anatomy to biology to pathology to treatment. 2-3 cancers we'll do. Okay, so do join me for that. And if you want to learn everything in surgery from me, please use my referral code 10surgery. Okay, and you can subscribe to any of the plus models, plus subscription. Okay, follow me on Telegram. This is my Telegram link, TME Unacademy Amrit Surgery, where you'll get updates about my YouTubes and special classes. Okay, guys. So hope you had a good, interesting class. See you tomorrow, same time. Take care. Have a good day. Study.